From Microbe TV, this is Infectious Disease Puscast, episode 72, recorded on Wednesday, January 15, 2025. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I will pre-warn people that I'm a little raspy and have that really lovely post-viral cough, so I'll do my best for that to not be a major discussion point today.
All right.
How you doing, Daniel?
I'm not going to make you banter too much then and wear out your throat. I got back from a week of vacation. I was very excited. It was nice to have a break. I set a personal windsurfing speed record.
Whoa.
It's a combination of frightening and exciting at the same time, but all excited to be back in the thick of it.
What is your record? What kind of numbers are we talking?
Well, I
have no reference point, so anything you say is going to sound amazing. So anything I
say is maybe our listeners actually. So, I borrowed my son's Apple Watch so I could record on this program called Strava, and I was up on a plane and just right in the zone, and it was blowing about 20 knots, and then a nice gust got me to a maximum speed of 35 knots or 40 miles per hour.
Wow!
And then I had a bit of a spill. So, and then you're, connected to the harness and you're under the sail and you can't breathe, all that good stuff.
Sounds like a nice mix of exhilarating and terrifying, like you said.
Yeah. No sleeping on my left shoulder for a really long time. We'll see.
Well, we'll get to healing in between the episodes. So Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, we're going to start with viral. I'm kind of heavy on the viral bacterial this week. And then Sara, if her voice holds, is going to pull us out. But continue to listen to This Week in Virology. I actually have a couple articles here in this first section I'm going to discuss in both ID Puscast today and then when we record TWIV. So human infection with a novel tick-borne orthonavirus species. Orthonorovirus, I think that's probably how it's best pronounced. Orthonorovirus species in China, published as a correspondence in the New England Journal of Medicine. So this, I have to say, I'm reading this, I'm so jealous. This is what I would love to be doing, this exciting viral discovery. And what happens here? So these researchers conducted an active surveillance of febrile patients, so folks with fevers with recent tick bites, at this Sentinel hospital in northeastern China, basically looking for causative agents. They performed meta-transcriptomic sequencing of serum samples obtained from 252 febrile patients, and they're looking May through July of 2023. They also used this de novo assembly to create the genomes of an unknown virus that they identified in serum samples from a couple of the patients. And the phylogenomic analysis, suggested that the virus belonged to the orthonorovirus genus of the Noroviride family. I say that because there's actually this taxonomic group, and then they get the final say. So, all that being couched when they noted that it shared less than 75.6% amino acid identity of RNA-dependent RNA polymerase protein with all known orthonorovirus members. They suggest that this is a new species, and they provisionally named the new species the Shui-Chong. Is that, you would do that, Shui-Chong, Sara?
I think so. X's usually like that SH sound.
Shui-Chong virus. After the native name of Mudanjiang City. I don't think we're supposed to do that, but okay, we're not supposed to name things after places where it was initially recognized. And they're calling it XCV. And this was detected in 6% of the Hemaphysalis consina ticks and 3.2% of the H. japonica ticks from the region where infected patients had been identified. And they've got these nice, different phylogenetic trees based upon whether you're going to use a particularly L protein or glycoprotein or the N protein. And then they go ahead and you can actually see cytopathic effects. So it looks like there's some real virus isolation here. And they've even got electron microscopy where you can actually see these what look like viral particles.
Yeah, it's very cool. And of course, lovely photos.
Right? I mean, it's beautiful. And, discovery, right? They discovered
it's really
something
cool.
brand new, and, bring this up like bar conversation, scare everyone away.
Did you hear about that new virus?
I found a new virus. Would you believe it? And it's in this percent of ticks. All right. So this next one, this is one of the two that are going to get hit twice. And so it starts off with my question of, why don't we use more Xofluza? And I was talking about this today, one of my colleagues. It starts off with the article, Antiviral Medications for Treatment of Non-Severe Influenza, a Systematic Review and Network Meta-Analysis published in JAMA Internal Medicine. So to compare effects of antiviral drugs for treating non-severe influenza, Medline, Embase, Central, Cinol, Global Health, a PISTA, Monocos, and clinicaltrials.gov were searched from database inception. I love that. To September 20th, 2023. And we probably do that all the time, right? We probably don't put like a pre-date on our searches. So we really probably are doing like database inception searches. The selected randomized clinical trials comparing direct-acting influenza antiviral drugs to placebo, standard of care, or another antiviral drug for treating people with non-severe influenza. So they're going to select those, and we're going to hear about those. And I'm going to make some comments in a moment. But mortality, admission to hospital, admission to ICU, duration of hospitalization, time to alleviation of symptoms, emergence of resistance, and adverse events were the main outcomes. So overall, they're going to look at 73 trials with 34,332 participants, compared with standard care or placebo. All antiviral drugs had little or no effect on mortality. Remember, this is low risk, but also high-risk patients. All antiviral drugs, and they don't have data for everything, so no data for peramivir and amantadine. Really little or no effect on hospital admission for low-risk patients, and they're going to say this is with high certainty. For hospital admission in high-risk patients, oseltamivir, really little or no effect, but baloxavir may have reduced the risk. All other drugs may have little or uncertain effect. Now, for time to alleviation of symptoms, baloxavir probably reduced symptom duration about a day, and oseltamivir probably no important effect. And really, for adverse events related to treatment, baloxavir had few or no. Oseltamivir, we did have some increased adverse events. So they're going to give us a summary. And in summary, they're going to say baloxavir likely reduces time to alleviation of symptoms by about a day, does not increase adverse events related to treatment, but it may be associated with the emergence of resistance in about 10% of those treated. Now, Tamiflu, oseltamivir, was found to have little or no effect on mortality and admission to hospital, likely no important effect on time to alleviation of symptoms, and likely increased risk of adverse events related to treatment, particularly the GI, right, the stomach issues. Now, the average cost for the one dose pack, so, the Xofluza is basically, here's 80 milligrams, just take one. It's about $200. You can get a little bit of a discount with a good RX coupon. Now, couple comments, right? So they put all these studies together, but as we've talked about some of these individual studies before, I had a chance to kind of review them in detail, there is a dilution of effect by a lot of these studies where the Tamiflu wasn't started until well after the first 48 hours. So, wonderful as piling up the cow pies and hoping they turn to gold. I'm not as convinced that Tamiflu is without benefit. But really back to my original question, why don't we use more Xofluza? And there's a couple issues here. One is the art of medicine is what I was talking about with my colleague today. Why is a Z-Pack 5 days when you could probably just take it, for 2 or 3 and just let it run out its half-life. It's that people are still sick. And so if you give them a 5-day course of Tamiflu, and it already took them 2 or 3 days to call you, by the time they finish the medicine, they're starting to get better. So I would say, listen, if you take the Tamiflu, you're going to be sick for about a week. But if you don't take the Tamiflu, you're going to be sick for about 7 days.
I can't believe I didn't know that the name for Baloxavir was Zofluza. I guess that's how infrequently I use it. Never comes up. Never had to learn the trade name.
Yeah. Now, the inventor is a listener of TWIV, so he always bemoans that Shinogi doesn't do a better marketing job.
Yeah, that's true. It's probably a marker of the marketing more than anything.
Yeah. And then, and sometimes you call it in, the insurance doesn't cover it, or they don't have it, and then time's going by. So, yeah. All right. So there we got Zofluza. And this is a fun article. I think you'll enjoy the title. Why the Ferrari of Viruses is Surging Through the Northern Hemisphere, published in Science. So why do they say Ferrari? We'll get to that. But the Ferrari of viruses is having a banner season, they write. Norovirus, which races like a Ferrari through cruise ships, homes, and long-term care facilities, is experiencing a remarkable winter surge in the Northern Hemisphere, sending large numbers of people racing to the bathrooms and many others to the hospital, and in rare cases, proving fatal. In the United States, for example, 91 outbreaks of the intestinal virus occurred in the first week of December 2024, far above the previous maximum 65 for the same week between 2010 and 2024. And levels of its genes, I like that, right? Because this is really nucleic acid in the wastewater. So levels of the genes in the U.S. wastewater are an order of magnitude above last year. And I did return from vacation to tales of many sick colleagues and a number of folks in the hospital with winter vomiting disease. And I don't know, Sarah, maybe this is a good for you and all our listeners. Why do we call it winter vomiting disease? Well, Albert Kapakian of the U.S. NIH discovered the first norovirus in 1972 from an outbreak of what was then termed winter vomiting disease that occurred at an elementary school in Norwalk, Ohio, hence the Noro in the name. And scientists have since described more than 40 major variants. So you can get this, 30 major variants. He gets like 30 different times. And this is all based upon the surface protein VP1, which is the main target of antibodies that can neutralize it. So you can get it like 30 different times with the different variants, but also as time goes by, you might be able to get the same again. And they have a really nice graphic that they created from wastewater scan. We get to see, oh my, what's going on in the Midwest.
Yeah. I also haven't heard Ferrari of viruses, but now I guess I can use that. I have thankfully avoided winter vomiting disease so far, so I'm going to knock on all of the wood all around me. So I meant to go back and get a viral article, and I think I just forgot. But I do have some articles in our bacterial section. Make sure to listen to This Week in Microbiology. The first paper I had is from Microorganisms. Beta-lactam's toxicity and the intensive care unit and underestimated collateral damage? ? Authors performed a literature search and summarized some of the neurotoxic and nephrotoxic adverse events associated with beta-lactams in adult ICU patients. They used about 75 publications in this narrative review. And I have to be honest, I mostly picked on it to zoom in on what they commented as far as beta-lactam neurotoxicity. They found reports of 10 to 15% of ICU patients having some type of neurotoxicity associated with significantly higher beta-lactam trough concentrations when that was available, although toxicity has not universally been linked to higher drug concentrations. Some people have probably heard kind of a rule of thumb or seen the publication before saying a minimal concentration to minimal inhibitory concentration, that C-min over MIC ratio over 8 has been correlated with incidence of neurologic deterioration up to 60%. But here, I thought one of the takeaways is they reported a relative activity, likelihood to cause neurotoxicity, as cefazolin and cefepime at the top, but cefazolin over cefepime. And then it was followed by penicillin, imipenem, aztreonam, amp, ceftazidime, meropenem, and so on. And so, as many people also know, the main risk factor that really increases that risk of possible neurotoxicity is associated renal failure, not adjusting those doses for patients who have decreasing renal function. And they actually had a section on TDM monitoring as well, with some suggested beta-lactam toxicity thresholds. I don't know how often people are using those in practically at the moment, but I thought that was helpful for me. And then the other half talks a little bit about nephrotoxicity. But I just thought I'd pull that out. It's like a number that you could potentially have in hand. But I thought it was interesting that cefazolin came out over cefepime.
Yeah, I was a little surprised, right? I'm thinking with all the cefepime we're now using, we're going to see higher issue, but yeah, it's
Yeah.
impressive.
And then for the carbapenems, at least they had the imipenem, because I've definitely looked up that clinical question before as far as like lowering seizure threshold and carbapenems. They do have, I think, like a separate paragraph kind of talking about that, the carbapenems in particular. Interesting.
Yeah, I mean, it's just so key to have a clinical pharmacist with you in the ICU. We were just rounding this morning, and it's just great. I mean, there's so many different
Yeah.
things, so much adjustments, drug-drug interactions, issues with protein binding. I mean, it's complicated, and these are sick folks. You don't really want to be making mistakes there. So. Excellent choice. Now, I was saving this one. I was so excited, right? I'm off on vacation. Before I get back, before I treat my next Pseudomonal aeruginosa infection, I'm going to read this and I'm going to know what to do. I bring it up on rounds. And is the article, What is the most effective antibiotic monotherapy for severe Pseudomonas aeruginosa infection? A systematic review and meta-analysis of randomized clinical controlled trials published in CMI. So, I mean, I'd like to know, and I'm sure all our listeners are waiting to know what's going to be the best. So they've got a total of 76 RCTs. They got 1,681 patients with pseudomonal infection included. Now, higher clinical failure rates of carbapenems versus piperacillin tazobactam were observed for pneumonia in 2 of the RCTs with a relative risk of 2.55. And higher microbiological failure rates with carbapenems versus other comparators, and that's about 1.24. Patients treated with imipenem were more likely to develop resistance to the study drug versus competitors, relative risk 2.3. But ultimately, before we take away too much, the authors conclude in this systematic review and meta-analysis of definite anti-pseudomonal monotherapy for Pseudomonas aeruginosa infection, they found no evidence for clinical benefit differences among direct antibiotic comparisons, but all subgroup analysis were underpowered to detect significant differences. And that's tough. 76 RCTs, 1,681 patients, and we still don't really know the answer.
Yeah. And the other paper I pulled was from JAMA Internal Medicine, doxycycline post-exposure prophylaxis and bacterial sexually transmitted infections among individuals using HIV pre-exposure prophylaxis. Here, we had some info from the scale-up of rolling out doxypep among HIV PrEP users in a California healthcare system, Kaiser Permanente, Northern California. This was a large cohort. They had over 11,500 people. And of those, 1 in every 5 patients receiving HIV PrEP received doxypep in the first year of availability. There's some information in there. The mean age of these patients was about 40 years old. It was mostly male, so like somewhere around 95+%. The receipt of doxypep was associated with substantial declines in chlamydia. The quarterly positivity decreased from 9.6% pre-doxypep to 2% after, with significant declines at each anatomic site. The Receipt of doxypep was associated with quarterly syphilis incidence decrease from 1.7 to 0.3% before and after that doxypep. And there were also some modest declines in urethral and rectal gonorrhea, but not pharyngeal. So I thought this was awesome. It's a nice look at doxypep uptake and clinical practice. It's mirroring what we saw in the clinical trials. I thought one other piece to pull out is that commercial insurance was more prevalent among individuals dispensed doxypep. So just kind of pointing to that potential role of access and other social determinants in patients actually receiving doxypep. But very cool. All right. And I pulled a fungal paper for us. I did look it up. The tentative release date for Last of Us Season 2 is April. So if people are curious, there's like tons of trailers and all of us anxiously awaiting it. The paper I pulled was from CID, Epidemiology and Prognostic Factors Associated with Mold-Positive Blood Cultures. 10-year data from a French prospective surveillance program, 2012 to 2022. This study identified 80 patients who had mold fungemia in that decade window that I mentioned. Fusarium accounted for about 2/3 of those cases, so 67.5%. Lomentospora prolificans was the second most frequent at 10%, and then at 5% each, they had Trichoderma, Aspergillus, and Mucorales. Most of these patients had hematologic malignancy, 70% of them, and then 43% had received an allogeneic stem cell transplant. And then as far as like types of infections, about 43% had cutaneous lesions, 43% reported pulmonary lesions, so those are the main things people picked up on. And the median time to blood culture positivity was 72 hours. The other big point of this, the 90-day mortality was 53%. And independent predictive factors of mortality included Lomentospora prolificans, odds ratio 33, Aspergillus fungemia, odds ratio 14.2, and then steroid exposure, they had an odds ratio 7.85. So just to look into when you do have those patients, you have mold in their blood cultures, but this actually is like a much bigger group than I would have expected, even if you were looking at like a decade. So I am kind of impressed they had 80 patients. We bring on plenty of papers to Puscast and Journal Club and stuff that often have fewer patients.
Yeah, I was really taken by the 90-day mortality. I mean, most of these people
Yeah.
are not around. And you always get, patients coming into clinic. Can you test me for mold,
Mm.
And just to point out, if you've got mold in your blood, you're probably not going to be around. It's not like, oh, just a little bit of mold in my blood. It's
Yeah,
pretty
not
serious stuff. So
Yeah.
not sure how that mythology got out there that, got all these mold positive, people wandering around just with, little bit of malaise.
Yeah. All right. Parasitic. Be sure to listen to This Week in Parasitism. Do you have any sneak peeks or trailers you want to mention?
We have some great ones. We just had one of my mentees come on to do the unveil, which was exciting. So yeah, we're just pumping them out every 2 weeks. So it's almost this week in Parasitism.
Nice. I pulled another article. I broke through. It's a little beyond the 2-week mark, but the video I'm telling you guys about came out this past week, so it still counts in my mind. But I just wanted to highlight how well I think there is a New England Journal of Medicine collaboration with Dr. Glaucom Fleckham, which I hope everyone follows, who is the world's best comedian ophthalmologist, but he has partnered with them to release these educational videos about publications that come out, playing on the characters that he's had. And so he has one with an ID doc about an article that came out in late November, Safety and Efficacy of Immunization with Late Liver Stage Attenuated Malaria Parasite. And I can't remember, you might have brought this article, but I encourage folks to check out the video. We can put the link. It is much more entertaining than anything I could ever say, but just to give you highlights, it's a small trial where researchers looked at the use of mosquito bites for immunization with GA2, MEI2, MEI2, single knockout Plasmodium falciparum NF54 parasite. And I really enjoyed, he gives a shout out to the participant, or as he says in his little skit, infectious disease heroes, who were the adults who were assigned to receive the either 50 bites from GA2 infected mosquitoes, 50 bites from GA1 infected mosquitoes, or 50 bites from uninfected mosquitoes. So we'll put a link to the paper and this short video, but hopefully there'll be more ID themed ones in the future.
Yeah, I actually have this article. It was on my floor. Apparently what ID docs.
Yeah, I was like, there's no way then.
I'm like, oh, I know this is right over here on the floor. It's a great article. I mean, really, I'm fascinated by all the development
really cool.
in the malaria vaccines. So yeah, and it's crazy, right? It takes people to be sitting there getting bit by the mosquitoes. So that's really the way to do it. So anyway, but and I am a huge fan of the comedian. And he's always very, very, I would say, nice to the ID docs.
He is, yeah.
We always come off very cool. So thank you. All right. So another parasitic article. This is albendazole ivermectin co-formulation for the treatment of Trichuria, and other soil-transmitted helminths, a randomized phase 2-3 trial published in The Lancet Infectious Diseases. And I'm really thinking about this as I get ready to head back to Panama in March with my buddy Ben Lebrot and crew. And, they go and they do these periodic deworming campaigns. And for a while, that was every 3 months. And then they did every 6 months because some financial issues with, affording all these medicines. But here is some interesting stuff. So these are the results of an adaptive phase 2-3 randomized parallel group active controlled superiority trial in 15 schools in Ethiopia, Kenya, and Mozambique. Eligible participants for both phases were aged 5 to 18 years, right? So school aged, weighed at least 15 kilograms, and were infected with T. trichuria, hookworms, or Strongyloides decoralis. Participants were randomly assigned via a computer-generated sequence to either a single dose of a fixed-dose combination, so FDC times 1, or albendazole 400 milligrams plus ivermectin, 3 consecutive daily doses of the fixed dose, which was albendazole ivermectin, or a single dose of albendazole alone. Basically, they're going to mix all the different things. And these folks actually, they tell us that a number of them, were infected with each different parasite. So first off, safety. No serious adverse events occurred. The T. trichuria, both FDC groups had a higher cure rate, so 97%. At 82.9%. When you compare that to just albendazole, which was only 35.9%. So pretty impressive. For hookworms, the fixed dose combination times 3 had a higher cure rate, 95% compared to albendazole, which was only down there at 65, so about 30% improvement. So the sample size for Strongyloides decoralis was not met, but really, I have to say, across the board, really encouraging support for this albendazole ivermectin co-formulation approach to mass drug administration.
Yeah, it's very cool. And I think I have a couple, miscellaneous papers that I pulled. Another one from New England Journal. A comparison of peripherally inserted central catheter materials. The trial name is Picnic, which is like delightful, and it gets pick in there, even though there's 2 C's. Anyway, so that one gets like...
They should have put 2 C's. They should have find
a way to get that other one.
Nick.
So excellent name. This was a randomized controlled superiority trial from 3 Australian tertiary hospitals where adults and children were assigned 1:1:1 to receive a hydrophobic or chlorhexidine pick versus a standard polyurethane pick, and they were followed for 8 weeks. So they randomized a little under 1,100 participants and ended up with about 365 of each of those groups. So hydrophobic, chlorhexidine, and then I'm just going to say standard, but standard polyurethane. The primary outcome was device failure, which was a composite of infectious or non-infectious complications. And they found no significant difference in risk between these groups. And so looking at that, device failure occurred in 21 of 358, or 5.9% of those in the hydrophobic group. It was 36 out of 363, which was 9.9% in the chlorhexidine group, and then 22 out of 359, which was 6.1 in the standard group. So 5.9 hydrophobic, 9.9 chlorhexidine, 6.1% in the standard group. In the hydrophobic group compared to the standard group, the odds ratio for device failure was 0.96. That confidence interval is 0.51 to 1.78. And the chlorhexidine group compared to the standard catheter, the odds ratio was 1.71. That confidence interval was 0.98 to 2.99. And I put one of the figures here, but I think, again, no major difference or benefit for one type of catheter over the other. Complications from any cause occurred in 21.5% hydrophobic, 38.6 in chlorhexidine, and 21.7 in standard. And so occlusion was the most common reason for device failure, not infection. And that was higher with chlorhexidine PICs than hydrophobic or standard polyurethane PICs, which occurred in 17% of patients in the hydrophobic group, 33% in the chlorhexidine group, and 14% in the standard group. They hypothesized that maybe this is due to some of the coating interactions. So again, take home is that there weren't really any advantages for the hydrophobic or chlorhexidine PICs. They were not associated with lower non-infectious or infectious complications. So, a standard PIC is probably a fine and reliable choice for OPAT. Maybe the next question is actually, does that patient even need that PIC line anyways, or can they do oral? But of course, that's a separate question.
And maybe duration, because looking at the figure, which is great. Really, the first 6 weeks, you really you get away with. It's really after 6 weeks that you really start seeing those complications. Participants with getting device failure. So, maybe if you can look at 6 weeks and then a transition to oral, even if you felt committed to that IV. So,
yeah. And then the last thing that I had pulled was from OFID. Wow, did I only pull one paper from OFID?
This is a great paper, though.
Personal record.
This is a great paper, though.
Yeah. So this paper was entitled "Considering Islamic Frameworks to ID Prevention," and it is a review that explores the integration of Islamic values in infectious disease prevention strategies, and the authors focus on concepts of, please forgive my pronunciation, tahara, cleanliness, la darar wa la dirar, prevention of harm, and maslaha, communal benefit. And there's, I think, a good component of talking about the role of community health workers. But they were focusing on these concepts and how they may be leveraged to help promote health interventions in a way that could resonate with religious and cultural values in Muslim predominant communities. And some of the ethics around that and how you can take an ethical approach to what is effectively mobilizing a religious value to align with a public health goal. And how, of course, that should be a combination of working together as a larger public health team and your community representatives like religious authorities. But Table 1 has some recommendations for some of these infection prevention strategies that they were mentioning kind of as a starting point. But I thought it was really cool to learn a little bit more. So hopefully we'll see I feel like OFID always has lots of great unique papers, and this is a good example of that.
Yeah, I'd agree. I mean, it's also another argument for why you really want, diversity among clinicians, right? I mean, ideally, you actually have a Muslim provider who is aware of religious, cultural values and how that meshes with a lot of the goals we have as providers. So.
Love it. Well, on that great note, we're coming to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher if you have a favorite podcatcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv, or just send them straight to me, which you guys keep doing, which is great. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com, and click on the donate button.
I'm Sarah Dong. You can find me on Blue Sky at Sarah Wynn Dong and Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center. Got the stint coming up next month. Or you can always find us here at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.